Well, hi everyone. My name is Dr. Josh Good. I work with Nashville Veterinary Specialists, as you well know. I'm emergency doctor there for 3 years. I am University of Illinois for 9 years, both undergrad and veterinary school. When I was in veterinary school, I thought initially that I wanted to do surgery, and so I was an emergency surgical assistant, an emergency imaging assistant, and then I accidentally fell in love with emergency by doing those jobs, and thus went and did an internship at VCA Aurora in 2015. It's a 38 doctor practice in the southwest suburbs of Chicago. ER was about 50% of our internship. We had anywhere from 4 to 6 interns working ER every day with an average caseload of 40 to 60 cases, of which I can tell you that caseload passed right on over here to Nashville Vet Specialists, of which we do see a pretty high volume of cases. I found that recently I average anywhere from 8, which is a lovely night, to 20 cases a shift. And our ICU usually averages anywhere from 20 to 35 inpatients of late. Topics. These are the main things that we're going to cover this evening. Seizures, intervertebral disc disease, congestive heart failure, arrhythmias, urethral obstruction, and toxins, of which I have a good number of toxins, as well as kind of one slide on each of them, which would be a nice thing to, if you want to have like a printout to be able to be like, bam, here's chocolate tox for technicians or what have you for the rest of your clinic. So, starting off with seizures. The first thing that I want to say when it comes to emergency medicine in general is don't freak out. So worst thing that you can do, my emergency clinician, my criticalist that was our intern director for my internship, told me one thing after I ran my first code and it didn't pass, which was, what would have happened if you weren't here? And it's like, well, we would have died. And it's like, what would have happened if you were freaked out and not been able to do anything? It's like, well, we would have died. What would happen if you just tried to go at it stepwise and tried to help it? It could live. And so just having that mindset of, not everything can and will be fixed, but that you're going to put your best foot forward and look at everything in a stepwise manner. That is by far the easiest way to approach any emergency, especially the more critical ones. First off, for seizures, we have 2 different types of seizures as far as main categories: your generalized seizures and your focal seizures. Your average seizure that you think about is a tonic-clonic seizure. Tonic meaning that we have muscle tension, clonic meaning that we have rhythmic motion. So your average is both. But you have seizures that are either or. You have myoclonic seizures, which are having like muscle spasms almost, looks like. And then you have absent seizures where you don't see anything with your musculature or anything like that. The dog's just kind of gone. I can tell you that those are very difficult, even more so than normal seizures, to come to a consensus on what the diagnosis is. And then focal seizures, your traditional that you would think of is like a focal facial seizure is probably your most common. Focal seizures, can they progress to generalized seizures? Absolutely. We see that happen pretty frequently, especially with when you have numerous focal seizures that they eventually progress. Causes. So your first cause that you want it to be is idiopathic epilepsy. Now, traditionally, we think of idiopathic epilepsy as a animal that does not have any pathological cause for seizures. It just, for whatever reason, has seizures, whether it be environmental, genetic causes. The average ages of onset are 6 months to 6 years, but I can tell you that in a lot of the recent neurology research that they have been finding a lot of late onset idiopathic epilepsy. So just because we're 10 years old and have a seizure doesn't mean that it has to be a tumor. Obviously, we get concerned when we get into double digits, especially with dogs, that these seizures are going to have some sort of pathological cause, but that's not always the case. As far as a diagnosis of idiopathic epilepsy, to be idiopathic, traditionally means that you've had to rule out everything else. So to have a true diagnosis of idiopathic epilepsy, we're talking about everything up from blood work UA, your minimum database, chest and abdominal x-rays, abdominal ultrasound, MRI. Does your average seizure patient do all of those things? No, they do not. I would say that for those, I want at minimum a baseline of CBC and chemistry to rule out some of the metabolic causes, but we'll get into that. Next, you have intracranial diseases, the most common of which would be like a tumor or something of that nature, especially in our older dogs, but CVA or a stroke, inflammatory disease, encephalitis, which can be autoimmune, especially in your little white shaker dogs, or can also be infectious with an infectious encephalitis. head trauma, which we'll kind of get to when we're talking about history with seizures being very important, and then hydrocephalus, especially in your younger patients and your apple-headed breeds, your chihuahuas, shih tzus, things of that nature. Then we have extracranial diseases, which are the main things that on any presentation that we're wanting to rule in and rule out, because these are the things that we might be able to do something about. To not necessarily have to treat the seizures, but to treat the underlying disease. Toxins, like I say, this is a relatively short list of things that can cause them, but I have seen bee sting cause seizures. Sago palm, which obviously also causes a lot of other problems, including liver problems. Chocolate, as it is an excitatory drug, essentially, as far as dogs are concerned. Illicit drugs for the same reason. Homemade Play-Doh, I've had 3 or 4 cases of that in the last month. Very high in sodium, can cause death. And so you think of Play-Doh ingestion, you're just like, just see if he throws up. I was very surprised when I had my first one called Pet Poison Control, that very, very serious. We ended up hospitalizing him for 72 hours. Then we get into metabolic diseases. Hypoglycemia is usually the first thing that we want to tick off, especially for any small breed dog. High blood sugar also can. Liver, kidney disease, significant electrolyte disturbances, especially hypophosphatemia, and anemia just due to tissue hypoxia. Accurate history. I cannot stress the importance of this for seizures enough. How many times has somebody had a dog, an owner come in and said, my dog had a seizure, and then as they explained it, you thought that it wasn't a seizure? By show of hands. Anybody? Yeah. And so seizures versus syncopal episodes versus a stroke, anything neurologic is a seizure to an owner. So when they come in, taking that at face value can be dangerous because we're not going to end up with the right diagnosis. Talking to them about the episode, making them explain it from top to bottom. I've had people be like, what, it was a seizure? And then be like, well, just for me, just, please. And then we find out that, it only happens when he's running in the backyard. You're like, well, might not be a seizure. We talk about syncopal versus seizure episodes being the main thing, and so a good history is important for that reason. When does it happen? The most common time for a seizure to happen when animals are in REM sleep. Now, obviously, they can happen at any point during the day, but if a dog's had 3 seizures and they only happen when we're sprinting like a madman chasing squirrels in the backyard, maybe we want to open up that list of differentials to some other things. Videotaping. Now, unless this animal has had seizures in the past or this owner is astronomically just like an amazing pet owner, the first time seizure is probably not going to be videotaped because they're probably going to be freaking out during it, which is natural and understandable. But especially if there's any question as to whether or not it's a seizure, tell them that if it happens again to try and get a videotape, because more often than not we're dealing with the aftermath of these things and they're very difficult to know exactly what they're seeing. That's the best way. And I tell you that anything that we're sending to Dr. House, she'll always prefer to have that if at all possible. And as far as these questions, types of seizures, which we already went through, duration and frequency, important obviously as far as whether or not we need to treat those. Certain time of day, we've had a large number of cases that have basically vasovagal syncopal events, and they only seize, quote unquote, after eating. And so knowing that information is great. Previous trauma, because as we previously noted, I'll talk to them about any major previous trauma that they know of for the dog. Does that necessarily mean that if they tell me that it hasn't had trauma that it couldn't? No, but if it tells me that it wasn't hit by a car 2 years ago, I'm going to look at that as a possible etiology. And then if we already had seizures, what medications are we on? This is very important because what are we going to do about it? Are we already on medications? Is that medication dosage or frequency appropriate? Do we need to go up on those dosages? Do we need to add a secondary medication, a third medication? And then also, how long have they been on? If they've been on those medications for 3 days, maybe we're not at the point where we need to add another medication. Maybe we just need to do something to give this animal some more time. And so we'll kind of go into some more of these things as we go on. But next, the second most important slide, which is when to treat. Number one is probably not something that's walking in through your door and you're wondering if it's seizures or not, which is identifiable structural lesion present, which means that it's had an MRI or a CT scan. We know why it has seizures and this is why. 2 through 4 is more what we're dealing with. Now, these are the last big neurology meeting. This was what was kind of set forward as the standard core. 2 being acute repetitive seizures or status epilepticus, which would mean an ictal event of greater than 5 minutes or a seizure lasting longer than 5 minutes, or 3 or more generalized seizures in a 24-hour time period, of which that statement becomes completely irrelevant when you say 2 or more seizures within a 6-month time period. So I say 2 because if it doesn't meet this standard, it still meets this standard. So I usually say 2 or more seizures in any 24-hour time period or within 6 months. Last being prolonged, severe, or unusual post-ictal periods. That's one that obviously is a lot more subjective than the first 2, but I would say the most important of them for me is always the 3, because that's going to tell me whether or not I need to treat. What to treat with? Okay, so a dog comes in actively seizing. We're a 3-year-old dog. We didn't get into anything. We know it's a seizure because it's happening. We want to give either midazolam or diazepam. Your clinic may have both. You may have one. That general dosage, 0.5 mg per kg IV, whether it be in hospital because we can't get a catheter in for whatever reason, or just because we don't have the money for a catheter, what have you. The per rectum dosage is usually 1 to 2 mg per kg, usually given with a red rubber catheter. That can also be done at home for dogs that have refractory seizures or just seize frequently. If I have a dog that comes in that it seized last about a week ago, it seized again today, it's normal now, but we need to get it started on medications, I'm not that worried about, the next week so much as I'm worried about, down the road. Maintenance dosing. Zonisamide has become the favorite of Dr. House of late, 5 to 15 mg per kg. Usually like to start in the 5 to 10 mg per kg range by mouth every 12 hours. Keppra and phenobarbital, which are a lot more of the medications that I use on an emergent basis. Keppra, we're wanting to go for 60 mg per kg per day. So if we're doing the Q8-hour Keppra, we're wanting 20 mg per kg to get to that 60. If we're doing Keppra ER, we want to do 30 mg per kg Q12, again, to get to that 60. Phenobarbital, that is supposed to be 2.5 to 3.5 mg per kg. I apologize. POQ12. That medication usually reaches steady state in 10 to 14 days without doing a load. And so knowing when these medications take effect is also important, because if we started a dog on oral phenobarbital 2 days ago and it's still seizing, we can't say that phenobarbital is not working, especially if we didn't load. Potassium bromide, certainly something that I've never prescribed, just working as an emergency doctor because of the steady state problem, which is right here. Now, certainly made changes to that medication, things like that, but that is usually something that we're looking at as, for me, a secondary medication, just because a lot of the dogs that I'm dealing with usually need to get some seizure control in the immediate to intermediate future. And then last of which is your cluster seizure, which is my most common presentation, which is an animal that's had anywhere from 2 to 22 was last week, I had a dog, seizures in a single day. Those are animals that need to get loaded on medication. Without loading them on a medication and knowing that we're doing something to get them up to steady state quickly, we cannot really say that we're actively controlling their seizures at that point in time. And so my favorite medication is Keppra, 60 mg per kg. You can do an oral loading dose and send them out the door if they are very normal at that point in time. A lot of times with cluster seizures, if at all possible, I like to have those animals hospitalized. I like to do additional blood work on those animals. But as we all know, your client situation, patient situation is always very in flux from patient to patient. And so as far as what we can do and what we'd like to do, a lot of times there's a gap between those things. And so an oral loading dose can be done in either of these medications. I prefer Keppra for whether it be an oral or an IV loading dose in hospital if I get to choose, just because the level of sedation that happens with any sort of loading with phenobarbital. Very effective seizure medication, not to take away from it, especially if you're going to do a load as I used to do in my internship, which was 4 mg per kg every 30 minutes for 2 hours and get up to a 16 mg per kg over 2 hours. Those animals would be very sedate for weeks, days. And so that would be up to 16 mg per kg, which would be considered a full loading dose of that medication. and so to refractory seizures. So we give the initial dose of midazolam, diazepam, and bam, we're right into another seizure. First off, I want to make sure that we're on one of these two medications, because if we're not on one of these two medications, we can't really expect to stop the seizures. Because the midazolam, the diazepam, they're stopping the active seizure, and there are some other things that we can do to help stop an active seizure outside of these, which we'll talk about in a second. But if we're not on one of these dosages, or not loaded on any seizure medication, we need to get loaded on those as we do these other things. If we're clustering and I know it and I have permission for medications, even if I don't know whether or not they can stay on Keppra long term, I like to start that medication even just for in hospital to get me control right here, right now. Because as an emergency doctor, that's my job, is tonight, let's say I'm working overnight, like I need to control these seizures tonight, because obviously we're not being controlled right now. So I'm going to do that 60 mg per kg loading dose. If we continue to seize, then what I'm going to do is I'm going to probably start a CRI of diazepam or midazolam, which is going to do well to kind of knock down some of those seizures. 0.1 to 0.5, I usually say that I start at 0.2 if we're really clustering and I'm really concerned. That way we can drop down to a 0.1 and then drop down off of it over time. And then if we've also had a large number of seizures, sometimes, and I'm concerned like we're not mentally appropriate, we're 3+ seizures today, we're looking rough when we're coming in, I'll also consider giving a anti-inflammatory dose of steroids just to try and get down that inflammation. Now, as far as what dose steroids, 0.5 mg per kg pred equivalent. As far as pred equivalent dosage for Dex-SP, what your dosage would be in prednisone divided by 7. So this is usually what I use for that. If we're still having seizures, then I'm either going to give another dose of Keppra. Now if I'm starting with like an IV loading dose, I don't know that I would necessarily go to a whole new IV loading dose. If we were already on Keppra and I was doing a 20 or 30 mg per kg dose of Keppra to try and just bring those levels up, that would also be an option. But beyond there, we're talking about either going to a propofol CRI, which we'll talk about in a second, can be a little tricky, or go to a secondary seizure medication, something like phenobarbital. Now, even with a loading dose of Keppra, sometimes it depends on who you ask, but usually anywhere from 6 to 12 hours is considered where it gets to steady state. And so, like I say, as far as like getting control in the here and now, doing that via either an oral or IV loading dose. IV usually in your really severe patients, obviously, that come in clustering, not appropriate. I don't recommend giving a dog that's severely postictal an oral loading dose and having it aspirate or anything like that. They obviously have to be alert enough for that. But I do oral loading doses of Keppra as well, in kind of those intermediate cases. Propofol CRI can be useful. The concern is the monitoring that has to go into a dog with a propofol CRI, being concerned about our airway, being concerned about our blood pressure, as well as the fact that though you're like, man, dog doing great on its propofol CRI, it comes off and it's like actively seizing and it looks really rough, it can just mask those symptoms where we can, our electrical activity can be increased, but due to the propofol CRI, we're not seeing the active seizures. And so that's very much for me a last-ditch effort. I usually don't get there. Have I gotten there? Certainly. But not something that I like to reach for first. The feline seizures, not quite as common. Of course, my first year of veterinary school, my cat started having seizures, and he went on phenobarbital. Very good seizure medication. Keppra can also be used in cats. I would probably say that those are kind of the 1-2. When we start getting into zonisamide, we start getting into some interesting territory, because it does have a longer half-life. Some people will say give it once a day. Some people say give it twice a day. I would say that if we're at the point where we're needing to figure out, like zonisamide and things like that for our cat, it's probably time to talk to Dr. House, at least for as far as I'm concerned. But same thing for loading doses for cluster seizures. Phenobarbital and Keppra can be loaded in those animals as well. Making sure that our clients know what the goal of therapy is, because I'm sure everyone's probably had the conversation of, I thought my dog wasn't going to have seizures anymore. We're on a medication, the first dosage of my first seizure medication. Why is my dog still having seizures? And that's not the goal. The goal is decreasing frequency, decreasing severity. And so seizures are, by definition, very individual and can be very frustrating. Obviously, we see a lot of refractory seizures at MVS, and sometimes it can be really frustrating when you got a 3-year-old dog that's on his 4th medication and it clusters every 3 weeks regardless of what you do. And there's always going to be those refractory cases, but doing your best to A, manage them in the acute phase if they're clustering, and then B, getting them started on the right medication or a right couple of medications. That's really what I see as, when we get past that, we're into neurologist territory. But as far as our jobs as veterinarians, I would say that those pretty much cover our bases. But certainly, if we had any specific questions as to like potassium bromide and things like that, like I said, I would not claim to be an expert on that, just because I only usually titrate those medications if they're already on them, rather than adding them on in hospital on emergency basis, at least, just because it's just not something that is going to help us out in the short term. They may very well get put on it when they get transferred to house, but not by me. On to discs. Well, we all know that there are quite a number of dachshunds in this area, as I have seen at least, and also seen quite a good deal of beagles and shih tzus, especially recently with disc disease. And so we have our neurolocalization, of which, as you probably well know, these are kind of the different sections that we break it up into, T3, L3 being our most common. Right there at the TL junction. I would say that as far as neurolocalization, the main thing that I am looking for when those patients come in and I'm suspecting intervertebral disc disease are, A, what's the history? What's been our progression? When's the first time that we saw, whether it be a front limb or a hind limb, be abnormal? And then how did it progress and over what time frame? And we'll kind of get into type 1 versus type 2 Hansens and why that's important. What are the limb signs? So what, doing my physical exam, what do we have? Are we, moderately paraparetic? Where's our paniculus at? Our deep pain? And then, are they painful / where are they painful? That's going to be, obviously, if you get pain at one location, you're going to have a good idea as what your localization is, because you can point to it. If you can't get pain, then that's where we really have to use our limb signs, paniculus, and everything like that to really come to that lesion localization. As far as how important that is, between a T3, L3 bladder and an L4, S2 bladder, it's going to let us know kind of what we're going to be worried about, constant incontinence or urine retention. And then, if we're dealing with C1, C5 versus C6, T2, I can tell you that if I'm certain at C1, C5, based on where my pain is, I put on that it's C1, C5, or C6T2. More often than not, just because those signs can come up really similarly, unless you're having like specific forelimb signs that would indicate a C6T2 lesion. It does say here severe T3, L3 disease can cause extensor rigidity called Schiff-Sherrington. If you haven't seen it, it's very notable when you do. But a lot of times those animals come in with that very two-engine, in that they got pretty much nothing in the front legs and we're very stiff in our front legs. Those animals are usually laterally recumbent, because the combination of those two things, regardless of how affected they are in the forelimbs, usually makes it difficult to stand. And so obviously noting the severity of it as well. And so as far as, like I say, most common, T3, L3, you're going to see paraparesis to paraplegia. You're going to be checking to see your CPs if they're present or not, usually the first thing to go. And then if we're painful, where, and then where our paniculus is. In severely affected animals, I do find that it's useful to shave the back and do a permanent marker to where our paniculus lies, because then that's the best way to judge its progression if we're concerned at all about myelomalacia, which again, we'll kind of get into later. All right, we'll go just briefly into the two types of herniation in the grand scheme of things. Without MRI, CT, and going to surgery, it's not as much of a concern, but just understanding it is important. And so type 1, you're going to see with most of your very sudden ones. It's going to be something where those animals come in where, we're normal, we jumped off the couch, and now we're moderately severely paretic, we're having significant limb signs, difficulty walking. Those would be the most common with type 1. And as far as what's happening, these chondrodystrophic dogs are having the degeneration of the disc, then the dehydration of the disc, which causes the mineralization, which we can see on x-rays, which is not a diagnosis for disc disease. Certainly if you have a dachshund that has mineralization on rads and it seems like it's T3, L3 lesion, if it looks like a duck and quacks like a duck, it's probably a duck. but I would not say that we can diagnose that definitively based on radiographs. It does not cause a lot for these animals. I'll usually have people tell me that it can't be that because my dog was just walking around. We were just walking down the stairs. Nothing happened. Unfortunately, disc disease doesn't care because it can. I've seen animals, like say, just walking and yelp out, and they're in here 30 minutes later and they're paraplegic. And it's unfortunate, but it does happen. HANSEN type 2. This is your more gradual onset. This is more of your chronic pain sort of dogs. Usually it's due to an incomplete rupture of the annulus that is usually bulging, pushing on the spinal cord, and so it's causing either intermittent pain or progressive pain. It's causing either intermittent signs or progressive signs. This can be a lot more variable. Usually your really emergent presentations are type 1, but they can technically be either. The difference between the two are just more about the kind of metamorphosis that happens within the disc, the outcome being largely similar, unless it's like a really chronic disc, of which if we're sending them to surgery, really chronic discs do not perform as well, just because we have a degree of spinal cord damage that's taken over time. Clinical signs, we already kind of talked about this a little bit. Type 1, sudden pain, weakness, paralysis, usually your typical kind of emergent presentation. Now, that also kind of depends on how observant, I guess I would say, to BPC, the owner is, as far as noticing when this is happening. Obviously, you have things that come in that say that this just happened, and we can tell that this has been going on for a while. So making that judgment on your own. HANSEN type 2 usually can be more one-sided, usually more slower onset over a period of time, and you're going to see a lot more of your neurological signs, but not quite as severe as these. And normally they're not as painful as your type 1 discs. Now, regardless of which type of disc it is, you have the option of doing nothing, starting on medical management, and considering surgical management. And so the large part of the frustration with this disease is what do I do and when? And so wanted to kind of definitely spend some time on this and certainly field any questions that I can on it. And so medical management, when I'm considering like this dog probably doesn't need to stay in hospital, if these owners are comfortable with it, this dog can be monitored at home, judging progression. We're talking about grade 1, which is pain only. We're not having any CP deficits. I'd see that very commonly for necks, of which a lot of neck discs I have that are just come in ADR painful, but they're not having any limb signs. Grade 2, ambulatory, with or without pain. We can have some ataxia, some CP deficits, but we're getting around, we're urinating on our own. Those would be the two categories where I definitely feel comfortable with trying medical management, which we'll talk about, versus saying that we need to go to neurology and consider surgical management. Now, for when we get into this, obviously really severe non-ambulatory paraparesis, urinary incontinence, especially if we have an upper motor neuron bladder, T3, L3, we're difficult to express or can't express. That's going to be something that's obviously going to be very difficult to manage at home. And so that becomes where we consider, hospitalization, aggressive management, often surgical management. And then obviously when we get into these areas, loss of deep pain, paraplegia, we're getting into more severe injuries. All right, treatment. So I usually break it up into kind of your C1, C5 versus your lower discs. And I would say that C6T2 is kind of your intermediate, of which I could have probably put it in both categories here. For me, the main thing is getting on pain control, getting on a muscle relaxant, and then considering an anti-inflammatory. I do not do an anti-inflammatory in all these cases. And now, like I say, I'm not going to say that doing an anti-inflammatory in all cases is wrong necessarily. Everyone manages these differently. I would just say that this is the common management that I do, of which Rossi does as well. Rossi House, that is. Pain management, gabapentin has been the most consistent pain medication. Our surgery service has gone to using gabapentin in all of our post-op patients, orthopedic or otherwise, just because of the spotty at best record with tramadol as far as our knowledge of its actual absorption and effect on animals. Now, have I given animals tramadol and I know that it works in some of them? Absolutely. So I'm not saying that that's not an option, but I would just say that I would prefer gabapentin over tramadol, and there's certainly cases that are painful that I do both in. Muscle relaxant, as far as between the two, it seems a little bit like subjective, but methocarbamol I find works best in our neck dogs, and then I find that diazepam works best in our lower back dogs. Now, as far as that dosage, we're going on the lower end of the dosage range for gabapentin for its muscle relaxant dosage. This is very commonly what all post-operative TL patients are put on by Dr. House. They'll stay on this for 5 to 7 days. And then we get into anti-inflammatory, which is definitely the most subjective of them. I would say that in acute neck cases where I'm not worried about, ideally we have renal values and they're normal, this, that, or the other, I like doing carprofen in those because I do think that it really aids in pain for the acute cases. For the chronic cases, I feel like less so. As far as when do I reach for steroids in these animals, I reach for steroids on a couple of conditions. One that we have acutely declined. You know, we have a dog that was normal last night, we wake up and we're severely non-ambulatory paretic or paraplegic, and we're concerned about just the progression of signs, usually within 24 hours. I would consider dosages doing anti-inflammatory low-dose pred in those kids, or Dex-SP pred equivalents in those kids. Now, if we know that they are on board for surgery, everything like that, I would usually say that I would transfer that and then let Dr. House make that call as to whether or not she would want them to be on steroids, because it does certainly increase bleeding intraoperatively. And so that being really the only detractor to it, but certainly we have given steroids of some nature in hospital to animals that have severely progressive acute signs. Here's a real treatment for a disc disease of which owners don't understand more often than not, and I feel like even myself, when I'm going through my spiel, sometimes gets left in the wayside, is that this is the treatment. Because people will be like, I've been giving treatment for weeks and weeks, and then my dog was running in the backyard and his legs went bad again. I was like, well, then we weren't doing treatment. And so really letting them know that those medications are all supportive care. This is the only treatment for medical management, is the strict rest. Everything else is just helping. Now, you can argue that your anti-inflammatories are doing something directly, decreasing that inflammation, which would be fair, but I would say for the most part, this is truly your treatment here. And that owners have to understand that, well, I don't want to do strict rest, I'm just going to go have surgery. They're going to be strictly rested after. And so strict rest, cage rest is needed in all of these cases, whether it be medical management hoping to avoid surgery in our mild to moderate cases, or even in severe cases, you know, it's going to be needed post-operatively. So letting them know that, you know, there is going to be a degree of nursing care that happens regardless of what, you know, medical or surgical management is decided upon. Questions?
What is the current recommendations now? So when they lose deep pain, how soon do they need to have that surgery done?
12 to 24 hours seems to be the consensus. I've heard both, but they usually want it within 24 hours. And that usually, you know, we try and err on the side of 12 in case that's the number, but a lot of times if it comes in acutely down, we kind of look at that, the time frame of signs. So let's say that it's deep pain positive, but it is plegic, and this has happened over 7 days. I would say that case, it's all always up to Dr. House or our surgeons that are cutting, but I would say that case is more likely to be cut the following day and started on supportive care overnight, versus your case that like this morning was normal and now is questionable deep pain, plegic. That case is more than likely to go, you know, that same evening.
What's your time frame for how long you recommend the cage rest?
Cage rest, yes. I usually say at minimum 2 weeks past the resolution of clinical signs, which is really difficult for people. Like I say, the cage rest is difficult to get buy-in on, and the time frame is always the most difficult thing to get that on. I usually tell them that they can expect anywhere from a month to 2 months of cage rest would be usually standard, because it's usually going to be, unless the signs are very, very mild, it's usually going to be at least a couple of weeks until they resolve, and then you want to be at least, you know, 2 weeks Some people would say 4 weeks after those clinical signs have resolved. But I'd say, especially if I feel like it's going to be difficulty getting them to do, the 2 weeks in general, I usually tell them at least 2 weeks beyond we think that the dog is normal. People usually feel like the second that their dog feels good that we can go back out in the backyard, and that's usually where we see our chronic pain dogs sometimes that could potentially be resolved, and then the ones that just will not resolve with medical management. Now, obviously, dogs can just not resolve with medical management as is, but I do find that that is my biggest detractor from all of that, is that just not getting them to buy in on the rest. Congestive heart failure, always fun. This is, we're not going to talk this to death or anything like that. This is a nice thing to be able to print out, post somewhere, think about in your spare time if you want to, if you're that kind of person. But this is basically about why animals, get congestive heart failure and what causes the fall of cardiac output. And so we see a couple of different very common etiologies for congestive heart failure here, with DCM causing myocardial failure, volume overload with mitral regurgitation, pressure overload, and high output with hypertension. Everything leading to low cardiac output, and then, like I say, we know kind of our nasty loop that we can get caught in here with low cardiac output, and why we use ACE inhibitors. But like I said, this is just a nice, pathophys kind of reminder here, but we're going to be dealing with more of the kind of practical aspect of it this evening. Presenting signs. We have usually tachypnic dyspneic animal cyanosis. Hopefully not moist coughing, but certainly can see that. If we're seeing that, then we have reason to be worried. Tachycardia, especially in dogs. I very commonly see bradycardia in cats. Hypothermia. This is really important with your initial physical exam, because 4 days ago, I had a cat that came in, grade 4 out of 6 heart murmur, dyspneic, had some increased lung sounds, and I was like, okay, well, this is a slam dunk. Temperature 104.6. Maybe not congestive heart failure. Maybe let's not just, zone in on just that straight off the bat, because not to say that that animal, due to anxiety or what have you, can't have a temperature that high, but we should certainly be thinking about other reasons if that temperature is not low. And then crackles. Crackles are a nice kind of slam dunk thing that we can hear without having to necessarily have x-rays, especially if it's a significantly dyspneic patient, to let us know that there's something severe going on in there. We have pulmonary crackles that brings down our differential list right away as far as dyspneic animals, whether it be a cat or a dog. But the absence of crackles does not mean an absence of congestive heart failure. So just make sure that we're not crackles yes, and then no crackles no. Make sure that we're keeping an open mind there. Reduced lung sounds, pleural effusion, especially in our cats, as cats, as they do in all things in their life, do whatever they want to do. Initial management. Initial management for congestive heart failure, despite the disease being really significant, is usually very straightforward. We'll talk about refractory cases and what to do with those, but as far as what's the standard of care for an acute dyspneic animal with suspected congestive heart failure, let's say ideally we've confirmed it on x-rays we're dyspneic, but we're not so dyspneic that we can't get a lateral rad in at least. Want to do oxygen supplementation when the animal comes in dyspneic. I want to give a dose of furosemide and butorphanol if congestive heart failure is on my list. So I will give, if I have permission to treat with CPR coming back and it's a dyspneic dog, it has a heart murmur and it sounds like it has crackles, before I even get a chance to do x-rays, anything like that, I'm going to go and do all three of these things right here. Because a single dose of furosemide, except with a severe renal failure animal, is not really going to cause any harm in and of itself, but not giving that and having a kind of delay in getting that medication could be detrimental. And the butorphanol, usually at pretty sizable doses, you can see here 0.2 to 0.3 mg per kg, because really calming down that breathing so that they are hyperventilating less than what they are when they come in is extremely important. As far as oxygen supplementation, can be as simple as just doing nasal O's while we're holding the patient. Ideally, we move from nasal O's to an oxygen cage situation if possible. And then pemobendin. Pemobendin I want to do in all dogs, I should specify, with congestive heart failure regardless of etiology. I'm okay with doing it in the acute phase until we get an echo. Do not necessarily want to do it in cats, especially due to HCM, but pemobendin can be very useful. The only time in a dog that I usually do not do pemobendin is if I just feel like I can't get an oral medication in this animal. It's dyspneic for whatever reason, to the point where I feel like trying to pill it or anything like that could cause it more harm than good and stress it out, and that's going to be when I lay off the pemo and try and lean on my other medications until we can get to a point to get that in him. Now, severe cases. I can tell you that the furosemide CRI is a beautiful, beautiful thing that I only started really utilizing more when we had this last big CE over in Opry and got to do the cardiac lecture there. It is so useful if we're able to, and all it takes is a syringe pump and some Lasix. It's not overly complicated to do. 0.5 mg per kg per hour is where I start. I'll go all the way up to 0.1 mg per kg per hour if I'm having a dog that has like nasal discharge, like, you know, they're pink frothy nasal or oral discharge. From there I'll go straight to that. This is actually the furosemide CRI. If you calculate it out versus giving like a Q1 or Q2 Lasix dose, actually ends up being less total Lasix that the dog's given. So it ends up being easier on the kidneys as well as usually I feel, especially having used it much more significantly over the last year, does better than doing continued Lasix doses just injectably. So if possible, use that. And the nitroprusside paste is something that we also are using in those same animals where I feel like I need to go strong up front. You can apply it to ears, make sure that you're marking it. We use our caution stickers on their ears if they've gotten it, so that way we know, because you don't want a technician touching that, because that can become a problem. And then obviously putting a wear glove sign on any of the patient's cages that have nitroprusside, even if they have markings on their ears, just because that's not a situation we want to get into. This area is where it becomes a little bit more subjective here. Sedation and intubation. You're only going to use this in your most severe cases. Dogs that look like they're actively dying and they come in, we're not craning, we're having severe discharge from our mouth or our nose, and we're just really worried about how this animal is going to do. These are usually the conversations where you're talking to the owner about euthanasia. I'm usually talking about them about euthanasia or sedation and intubation. Now, I usually tell them if it's really severe and advanced, it's not to say that we can't try medical management and everything, but I can say that I feel like most doctors, once they've seen enough cases of congestive heart failure, can see the ones that they feel like really are going to have a hard time resolving with just medications. Sedation and intubation does have the advantage of letting us get control of that airway and dump some of that fluid off, whereas we don't really have any other way to do that. Now, obviously the concern is that couldn't these animals not wake up from sedation? Could the sedation cause increased hypotension, which causes them to further go into heart failure or to even go into asystole? All of those things are possibilities. So if we're having this conversation with them, we're having usually an end of life or kind of we can try this sort of situation. Now, that being said, I have had animals that I feel like would not have otherwise make it because they do well under sedation and intubation. Usually I'm going to sedate them, ideally with usually a combination of torb. I like to lean away from propofol if at all possible. Alfaxalone works well, and that's becoming more prevalent in our clinics. And then the intubation, I want to intubate, try and dump the airway immediately after we intubate, and then doing positive pressure ventilation, which is going to really help get that oxygen into those cells. If we're at this point, we're at a very severe state. I would not say that I would offer this for our moderate cases by any means. Things to avoid in congestive heart failure. If you know that the animal has congestive heart failure, it's very easy to say that we won't give them IV fluids or steroids. If we have a cat that comes in that's a dyspneic cat, that might be asthma, it might be pneumonia, it might be CHF. Those are probably going to be our three most prevalent options. If we hear that we have increased lung sounds we believe to be crackles, those would be my top three differentials. I would say in those animals that giving furosemide might help, won't hurt. Giving steroids might hurt, might help. giving steroids in those animals, especially if we're giving them something that has a long half-life, especially, anything DexSP and up, we're giving them something that we can't take away. And so if we find out, an hour later that animal has congestive heart failure, we're really working uphill against those steroids, which are going to aid in fluid retention, which is the exact opposite thing that we're trying to achieve. And so I would say that if congestive heart failure is a differential, I would hold off on steroids if at all possible. Now, obviously, patient to patient, what we think is going to be right or wrong for that patient, but I would say that if we're thinking it's asthma or congestive heart failure and give a dose of Lasix and a dose of steroids, that's a good thing if it has asthma, and it's a bad thing if it has congestive heart failure, treating both in that instance. All right, arrhythmias. I'm going to kind of talk about just arrhythmias in general, a couple of things that aren't big problems, and then we'll do ventricular tachycardia and supraventricular tachycardia real quick. Your ECG, P, QRS, T. The things that often go overlooked are your PR interval here being very important, as well as the placement of your T wave, and we'll kind of talk about that. These are kind of the questions if you're starting to get into arrhythmias and worry about things. These are the questions that you need to be asking yourself. What's the rate? Because that's going to decrease your differential list right there. If it's 40, you have a certain list of differentials. If it's 200, you have a certain list of differentials. So you can rule out a lot of things just right off your rate. Where's the P wave? We'll look at some examples here in a moment. Is it present? Is it always in the same spot? Is it associated with our QRS complexes? And then that PR interval that we just mentioned, is it constant? That's going to be where you get into your first, second, third degree AV blocks. And then QRS complexes, what do they look like? Your primary concern would be for an abnormal ventricular arrhythmia or a ventricular premature complex, but there are certainly some other things that you need to watch for with QRS complexes. Really, your first degree AV blocks are a non-issue. Where you start getting into issues is recognizing your second degree Mobitz type 1 and your second degree Mobitz type 2. These are two different arrhythmias, and I kind of highlighted what we'll see up here. So we'll see that your rate can be whatever. Your rhythm is going to be pretty normal, but you're going to have an occasional missing beat, so it's something that might not be very readily apparent based on thoracic sculpt. Your P waves are all normal, but your PR interval is increasing with each heartbeat. And then after it misses, we miss a beat, and then we go right back. And so we can see here, there's our P wave. That's our PR interval right there. Here's our P wave. See that much bigger interval there. And then this kind of buried in the T. There's our P wave. And then we're missing a complex, and then we're right back into it. And then it's going to get progressively longer and longer from there. Type 1 does not progress to third degree heart block, generally speaking. And so this would be a heart murmur or a heart arrhythmia that you listen to / look at on ECG strip that would be considered largely non-pathological. Whereas your Mobitz type 2, you're having your PR interval is constant, but your rhythm, you're going to have missing beats. And so when you look here, this PR interval is all great when we are looking at these QRS complexes, but we're seeing all these lone P waves just kind of hanging out here. This is a really kind of overt one where you can see it's pretty regularly every other beat being missed here. That's not always the case. But that constant PR interval is what tells us that this is Mobitz type 2, which is something that can progress into type 3. So this would be considered a pathological heart murmur. It would be something that you would ideally want to refer and have seen by a cardiologist. Then our third degree AV block, which means that we have P waves, we have QRS waves, and they don't know each other. There's no correlation between the P waves and the QRS waves. Your PR interval is completely inconsistent, and then a lot of times your rate is significantly decreased. I've seen third degree AV block with a heart rate of 32 that walked in looking fairly normal miniature Schnauzer. But exercise intolerance is going to be the top thing that you see with these kids. Unfortunately, third degree AV block is something that's going to require a pacemaker. Right now, something that MVS looks to be able to add to our stable of things that we can do, but not until we get fluoroscopy, which is required to place these. And so right now, I believe we need to refer to UT if we need that or another teaching hospital, depending on where you are. Ventricular arrhythmias. This is why arrhythmias are on the list, because I see ventricular arrhythmias very frequently. This is going to be right in that differential list for seizures, syncopal episodes. Any boxer with seizures is getting an ECG in my clinic, because that is definitely going to be a rule out, or any big dog that I'm concerned about, DCM, VPCs, anything like that. Certainly if I have any sort of pulse deficits when I'm doing my physical exam as well. So ventricular premature complex, wide, bizarre, QRS complex there. We can see the normal QRS complex next to it. Ventricular tachycardia, by definition, is when enough of these line up in a row that we are having tachycardia. As far as when I consider that treatable, I would say above 180, or if it's causing a problem with cardiac output. So let's say that we're having VTAC, it's 160, the dog looks otherwise normal, but I'm having significant pulse deficits, or we have a low blood pressure, I would indicate treatment on that. Certainly not saying that a 160 BPM VTAC dog is just going to be sent home like, never mind, you're good. But as far as what's going to require really emergent resolution of that would be 180 plus, because that's usually where it's causing enough of a concern for cardiac output. This is VPIB. Your patient with VFib is probably going to look a lot different than your patient with VTAC. If you're looking at an ECG of a laterally recumbent 12-year-old boxer and you're trying to judge the difference between these two, you should still have, though they may be wide and bizarre, a definitive QRS complex. Now, they can be variable, they can be multifocal, and when they are, that is where a lot of the confusion comes between that and ventricular fibrillation. But these should be causing pulses. These ones aren't. And so listening to the heart while looking at your ECG, utilizing your femoral pulses is probably the thing that I would say helps me the most in differentiating out arrhythmias, especially leading to my concerns for VPCs and things like that, is your pulse deficits when you're listening to the heart. So I would say in those animals, make sure you're doing both at the same time. How to treat. First, hook up to ECG ideally and give a 2 mg per kg lidocaine bolus slow IV. Slow, I usually say to give it over 1 to 2 minutes. It's usually a fairly small amount, and so we're just doing a slow continuous push rather than giving over 10-15 minutes. What I want to see is a visible reduction in either a stop of our ventricular tachycardia or a noticeable improvement in it. Now, if we see a significant improvement in it and 5-10 minutes later we're right back to where we were, that doesn't mean that the lidocaine didn't work. It means that the lidocaine's half-life is kicking in. And so these animals usually require lidocaine CRI. And so if we have significant concern for a heart problem in these animals, and we know that we can't be on a lidocaine CRI for a very long period of time, I would at that point consider doing a sotalol or mixilotine in addition to the lidocaine CRI, so that way, just like how I can use the Keppra to get a short-term control and then add on a different medication to do the longer-term control, I can have the lidocaine CRI helping us out in the short term and get one of these medications on board, so that way when I come off the lidocaine CRI, we don't just go right back into VTAC. Now, I would say that if we don't have these medications, we're not comfortable with these medications, I think that that's perfectly understandable. These are ideally something that are prescribed by a specialist in a lot of occasions. Now, I would say that sotalol is probably the most used of these medications on an ER basis. It's something that my only real concern for it is that it is a LOL, which means it's a beta blocker, which means that it can cause decreased cardiac output. So it's definitely not a medication that is a, can't do anything, can't go wrong, let's put it on sotalol. But I'd say that in severe cases, if you feel like they're not going to refer, we're having severe VTAC, we really need to do something that's going to be able to get us out of hospital, sotalol will probably be the first drug that I would reach for in those instances. Supraventricular tachycardia. That can be very commonly, especially if it's very, very fast, and some of these P waves start riding up on some of these QRS complexes, we can really have where we can, see that these get misdiagnosed as ventricular tachycardia. I would say that, again, feeling our pulses and our pulse deficits, that's going to be an important thing. And then in these instances, if we're having a severe supraventricular tachycardia, it's not necessarily wrong to, if you do think that it might be ventricular, to try lidocaine CRI. I would not expect to see any impact, obviously, if that is a true supraventricular tachycardia. Now, as far as the treatment for these, we're talking about doing beta blockers as far as a primary treatment for this. Never, ever touch a beta blocker until we consider our volume status and everything else that's going on with this patient. Why do we think that it has a supraventricular tachycardia? Are we hypovolemic? Do we have concerns for congestive heart failure? If we're hypovolemic, we don't have concerns for congestive heart failure. Let's say maybe this is possible, like a trauma patient, or we were hit by a car, or we don't know what happened. The owners found him and now he looks like this and his heart rate's 200. We believe it to be a supraventricular tachycardia. Treat volume status first, and then really kind of have a thought about what else this could be in treating our underlying cause. Could it be pain? Could it be, any number of toxin ingestions, what have you? The beta blocker is, for me, always a last ditch. I would say that the most common use of this in the supraventricular tachycardia is for chocolate tox, for me, personally at least. But I would say that even in dogs that come in with their heart rate over 200, I would say that more often than not for chocolate tox specifically, that probably only about 1 out of 20 of those animals truly needs a beta blocker. Most of the others with fluid boluses and mild sedation, I can get that heart rate down. So I would try those things before I would reach for a beta blocker. Again, because we're talking about decreasing cardiac output. It's not a medication that doesn't have side effects. Everyone's dealt with UOs here, I can almost assure, but especially the severe cases is what I'm going to be kind of honing in on. So as far as history, strange urea, dysuria, peeing outside the litter box, abdominal pain, strange behavior, these are all going to be things that are, especially in a male cat, they're going to at least have me, probably the first thing that I'm going to do in that physical exam is feel for that bladder. What I'm going to find usually is an overdistended turgid bladder, usually painful. Can I express it? Now, I am not cranking on these bladders, obviously the ones that are severely distended. Now, should I be able to rupture a bladder with just my hands? I mean, I'm not a particularly strong person, so probably not, but it's just something that I would not recommend doing, just because I want to be careful. Now, what I do want to do is I want to examine the penis. Now, just because we have like an erythematous tip of our penis or a red to purple tip, does that mean that it's a UO? No, but if that's true and everything above it is also true, then it probably is. And so that's just something that I help to make an initial diagnosis or initial concern that we're obstructed. So if I have an overdistended turgid bladder, I put mild to moderate pressure on it. I can't express any urine. I look at the tip of the penis. It's erythematous. It's a male cat. My top differential at that point is going to be a urethral obstruction. Body temperature on here, because sometimes it can be low in our severe cases, but a low body temp doesn't necessarily, I just want to add that doesn't necessarily make it diagnostic for this. Diagnostics. I can tell you that a lot of these diagnostics are usually being done as we're doing things to get ready for an unblocking procedure, especially in severely affected animals. The most important things that I'm looking for are usually right here in my chemistry and lights. UA, I'm usually getting after the fact, after I've already catheterized. I'm getting it off the catheter because that's easiest, as long as I didn't have to do a cystocentesis therapeutically. Abdominal radiographs, I'd say if we're stable, I'd like to do those before because I'd like to know if we have stones or not. If we're really critical, I will try and go ahead and place a catheter and do a placement radiograph for the UCath postoperatively to see if that's a concern. ECG would kind of go along with the chem and lights. If I'm seeing that we're severely affected, I want that ECG. Now, everyone always hears about hyperkalemia, tall tented T waves. It's great when you see it. Is it always apparent on ECG, even with really severe hyperkalemias? Not in my experience. And so, if you see it, then be worried about it. If you don't see it, don't assume that that potassium is normal. As far as what to look for, we're seeing the kind of difference between a normal QRS and this one. The main things being the tall tented T and the increase in the PR interval are usually going to be the top two things that I can see really hone me in on that. If I'm at the point that I'm doing an ECG on these animals, I either got permission to do full blood work and that's running, or I'm going to do, in my clinic, do a venous blood gas, because that's going to give me lights as well as our pH, which can be useful in their rehydration. Even just a light strip is going to be useful in that instance. OU treatment. Fluids are necessary in our critically or severely ill cats. Now, depending on what's going on, do I want to give especially fluid boluses to a cat or a high fluid rate to a cat that already has a severely turgid, distended urinary bladder and we're going to be able to get to the UO in the next hour to 2 hours? No, because that's not a good situation. I want to ideally get that procedure done quickly, have those fluids ready, and that those fluids start the second that I get that catheter in. Now, that's not to say that we can't do before, and we'll kind of talk about instances where a therapeutic cystocentesis would be warranted, which could be something that you could do and then start those fluids as well. I just don't want to cause a bladder rupture, especially if we don't already have one. Now, your hyperkalemia. Now, this is my favorite table. I got it printed out, got it at my computer, and this basically tells me that based on what my potassium is, how significant of treatment do I need to do for it. Now, the best treatment for this hyperkalemia is what? Correct. That is going to be by far the best treatment for the animal, but if that potassium is really severely elevated, we need to be worried about the sedation in that animal, bradycardia, its cardiac output, all of these things. And so I usually say that if it's mild, for less than 6, then I'm starting on fluids, I'm just getting going, I'm getting unblocked. If we're above 6, in the 6 to 8 range, that's when I want to do a 1 mil per kg fluid bolus. Usually, basically what I say is, let's say we have a 10 kilogram cat. That's a big cat, but it's an even number. I do 10 mils of 50% dextrose, 10 mils of normal saline. That gets us to our 50% dilution. We just don't usually want to give 50% dextrose IV just because it's caustic and it's acidic. And that's immediately followed by a unit of regular insulin, IM or IV. And that's to just drive that potassium into cells. And then severe hyperkalemia, calcium gluconate. Now, this calcium gluconate is doing nothing for what your actual serum level of potassium is. What it is being cardioprotective. When you're above 8 MEQs, that's where we can really start to see that bradycardia and everything develop in these animals. And so the calcium gluconate is a cardioprotectant. Ideally, when you're on calcium gluconate, you want to be on ECG. You want to give it over 20 minutes. And then, like I say, we're still, basically, if you're doing these things in this order. So if I'm doing this, it means that I'm also doing the mild and the moderate as well. We're doing kind of progressive care as this goes down. I found this chart very useful for that instance. Treatment. Cystos. Usually a pretty controversial topic. Some people love doing them, some people hate doing them. Bottom line is no one's wrong. They can be very useful if we think that poking the bladder is going to be enough to cause a complete rupture. It's a very abnormal bladder. That bladder should be able to take that. We can dramatically reduce the bladder pressure. In some animals that are very severely distended, that pressure becomes the main reason that we can't get that catheter in, that back pressure. And so sometimes I'll find that I need to do that in order to get the UCath in. And it improves our GFR almost immediately. That potassium's going down. We're improving GFR, so our azotemia is at least not going up anymore and ideally coming back down because we've been started on fluid therapy after this. Now, we usually want to do these with like a 3-way stopcock because obviously it's not something where we want to be holding a needle in that bladder or poking that bladder multiple times, obviously. One and done, ideally. Aortic puncture, also a con. If we're doing it with ultrasound, the chances of that happening less, but not zero. As far as sedation, Everyone has a different sedation protocol. I'm not saying this is right or wrong. I'm just telling you this is what I use. We see a lot of black cats. I like using this combination of things. I like using methadone over using buprenorphine just because it's stronger and it really helps relax them a little bit better. Midazolam, A, for the sedation property, and B, for a little bit of relaxation of that urethral sphincter, and dexmedetomidine just because I like to be able to immediately reverse that medication if at all possible. Now, if I have any concerns for it, placing a catheter and doing alfaxalone, or not placing a catheter and doing alfaxalone would both be options. And I have put some of these cats under general anesthesia, intubated them if I have really severe concerns. Because then I don't have to give these big dosages, especially if I have any cardiac concerns as far as doing dexmedetomidine. Difficulty on blocking. We already talked about therapeutic cystocentesis as being a option. Coccygeal blocks, really underutilized. They're extremely useful for these if we're feeling like we just have like a lot of tone. We're not having a lot of grit. We just have this terrible tone that we can't get past, and we don't feel like the bladder's overly distended to the point where a cysto would be helpful. The coccygeal blocks can be really useful for that. And then last of which, the rectal, is so that we are blocking off our urethra with a friend via a rectal, and so that when I'm flushing, we're kind of doing pulse therapy to try and push back any grit back into the bladder. That's not something that I feel like I have to do frequently, but I've certainly had to utilize that technique previously. Catheter placement is pretty standard throughout, just given the shape of everything. The things that I find most useful, I do most of mine in dorsal recumbency. Everyone kind of has their own thing, but I'd say dorsal recumbency the most common. And then the most important thing is getting the penis extruded and then pulling it down and straight, at least in a dorsal recumbency. I mean, the best ways to straighten out our urethra here and give me the best chance of doing this nicely, quickly, hopefully in one try. Beyond that, we have what are our medications that we use going forward in these. I would tell you that the medications that I use are buprenorphine, prazosin, plus or minus an antibiotic if warranted based on what we find on UA. Prazosin is listed as 0.25 to 1 mg per cat. I use 1 mg per cat and only like Maine Coons pretty much. 0.5 mg per cat is probably by far my standard doses. 9 out of 10 cats are on 0.5. I do it Q8 in severely obstructed cats in hospital, and they usually go home on Q12, but I have done either, especially if we're a repeat offender, tried to do the prazosin more regularly, or sending it home on a more prolonged course may be warranted. Buprenorphine, A, because it's painful, and B, because if we want to decrease their stress level, watching cats trip on buprenorphine is usually useful for them and entertaining for us. Some of the funniest cats I've ever seen on buprenorphine, easily. Catheter, how long does it stay in? 24 to 48 hours is kind of the generic answer to that. I would say at minimum 24 hours, ideally. Now, obviously, we've all run into instances in this where you need to do an unblock and go, or what have you. But I would say that if a client comes in and says, there's, cost is no issue, everything like that, hospitalization is fine, ideally, we're keeping that catheter in for 24 to 48 hours to really give that urethra a break. And then, like I say, antibiotics if warranted. There's nothing wrong if it's a really nasty cat and they don't want to do a UA, doing a convenient injection or something to that extent, or doing clavamox. Ideally, they let you do a UA, and then I will sometimes treat, if I think that, just based on the urine look or anything is suspicious, I'll treat with Unison overnight until I get back the UA the following day, if we're sending it out. Toxins, fun stuff. We get a lot of them. The best thing that I can tell you about toxins, poison control. It's your friend. The owners can call. If I get a call saying that my dog ate this, I'm coming in, I say, start the phone call on your way in, because a lot of times they'll complain about the wait times on hold, etc., which is usually my same complaint with ASPCA poison control. Sometimes I'm sitting there at my computer for 25 minutes waiting to talk to a toxicologist, but the information you get is invaluable. Like I say, I called poison control on that Play-Doh which is not something that I had run into before, which is not something that I would have been overly concerned about in and of itself, just hearing it over the phone. I'll always tell people I never know, and that's why we check. I like moving forward with more information, as much information as possible. If someone calls about a toxin and I know that they're coming in, we give them the phone number over the phone and we tell them to call. The treatment recommendations and everything like that, even if the owner doesn't want to do them, the information that they give us as far as how to treat is, like I say, invaluable. First rule of toxins: decrease exposure, inducing emesis. Indicated most of the time, not all the time. As far as counterindications, kind of listed down here. If we don't have the cognizance to vomit without being concerned about aspirating, severe marijuana tox dogs and things of that nature, I'd say is probably where I've been running into it most often, is that I don't feel comfortable making those animals vomit just because I'm too worried about them aspirating at that point in time. As far as how to induce emesis, apomorphine is going to be our best way to do it. If apomorphine doesn't do it, I've done IM morphine, just like the pre-med, just because it will usually make my pre-medicated dogs vomit, so it works for these animals as well. But then you're having to battle the sedation caused by the morphine unless you're reversing it with naloxone. So again, apomorphine is going to be your best choice, obviously. Hydrogen peroxide, something that we can tell owners at home. Unfortunately, sometimes owners kind of take this and run with it. I usually tell them about, max dose, don't give more than this, and then they'll come in and they're just like, we gave it like 3 pulls off of it, and you're like, okay, that's a lot. And they say that it didn't vomit, and then it turns out the dog didn't eat anything, and then the dog's back in the ER the following day because it's having, severe vomiting, refusing to eat, and it's just because we just gave it esophagitis, gastritis, all those things. And so it's definitely not without some concern that I recommend hydrogen peroxide. I'll usually recommend that for people that basically tell me outright on the phone that they're not coming. What can I do from home? I give them that as an option. Inductions of emesis in cats, always a fun thing to do when you're in clinic. I would say that the thing that I find the most useful is probably this Dexmed dose. I believe you can do anywhere from 7 to 10 mg per kg IM of dexmedetomidine, and I have those animals monitored throughout that process, and I have antecedent on hand for that process as well. But again, just kind of back to your IM morphine. Certain things given IM have a chance of making animals vomit, and I find that Dexmed at that dosage in cats works pretty well. The xylazine dosage is all right. I've seen it work. I've seen it not work. I'd say that the xylazine probably works in 1/4 of the cases, and I probably say that Dexmed works in about half the cases, and then half the cases nothing works because they're cats. And then the hydrogen peroxide, it's on here. If we're concerned that this cat ate something to the point where it could die and it is not going to come into your clinic, that would probably be the only iteration that I would say, why don't we recommend to this owner to give this cat hydrogen peroxide? Because A, it's not anywhere near as effective as in dogs. B, it can cause GI bleeding in cats. And C, the owner's probably going to quick care after getting bit by their cat after trying to give it this hydrogen peroxide. It's not going to enjoy that, and it's probably not nearly as tolerant as their dog would be for it. Continuing to decrease exposure. Activated charcoal is super useful in our patients. Again, we want to make sure that we are, A, not needing to make them vomit before we give them activated charcoal, because if you give them activated charcoal and then you got to make them vomit, you got a problem on your hands, because they aspirate that and you got potentially severely affected patient and angry owner and a problem on your hands. And so ideally I'm going to make them vomit. I'm going to give them Serenia. I'm going to have a lapse in usually 15-20 minutes at least. I'm not seeing any further vomiting or anything like that. We're not hypersalivating, and that's when I would give activated charcoal. I have given activated charcoal via an NG tube in animals that I don't feel are neurologically appropriate enough to ingest it, but we also have to make sure that those animals aren't actively vomiting, because if they're not appropriate enough to eat it and they're still vomiting, then obviously that aspiration concern comes right back in. Now, if vomiting's not part of their problem list and we just feel like we need to get activated charcoal on board because we can't make them vomit, then doing it via an NG tube is certainly an option that we have. Gastric lavage, very rarely do we do gastric lavage, I would say. It can be useful, certainly in specific cases. I usually do gastric lavage when ASPCA poison control tells me to. that would probably be the most common time that I would do it. I don't do it specifically for any one toxin. I usually am able to manage most of them without having to do gastric lavage. General mindset: making them vomit plus or minus activated charcoal. IV fluids, if we don't know what it is especially, are going to be three things that are going to be generally fairly useful for you, especially when a 1-year-old dog comes in that was fine, it was out in the backyard, and now it's acting, whether it be neurological or vomiting, what have you at that point in time. If a toxin's on your list, these would be things that are generally useful for you. Obviously, if you know exactly what it is, ASPCA Poison Control should be telling you exactly what you need to do. Now, if an owner is not willing to call ASPCA Poison Control, then, like you say, kind of back, or we don't know what it is, we're kind of back to doing kind of the general things, decreasing the amount that's absorbed and then doing supportive care as needed. And so in addition to this, I would say that, for having muscle tremors, give a muscle relaxant, what have you, supportive care in that way. Now to some specific things. I intentionally made each of these their own slide, so I apologize that there's a lot on them, and that's just so that it's all kind of contained in one spot. Chocolate is essentially, and it's hard to get owners to think of it in this way, a stimulant toxin. And so I generally think of it in kind of 3 stages. Your mild, moderate, severe. Your mild, you're mostly looking at your vomiting, diarrhea, your GI signs. Your moderate, you're starting to get into your restlessness, your tachycardia, plus or minus some muscle tremors. Here, you're getting into your hyperthermia, severe muscle tremors, seizures. In either of these, I have seen tachycardia that needs to be treated. I would say that the severe cases are usually the only ones that I need to use a beta blocker in. These moderate ones, usually a fluid bolus and a dose of Torb to knock down their hyperactivity is usually enough to really decrease that heart rate in and of itself. Treatment, decontamination, making them vomit, doing activated charcoal, usually doing a single dose depending on what type of chocolate it was. The gastric lavage, like I say, I've only ever had to do that once in a very severe chocolate tox dog. He had gone to the point where he was in status, so we actually anesthetized him so that way and intubated him so I could protect his airway, did a gastric lavage, put in activated charcoal, did aggressive IV fluid therapy, we had to do beta blockers, everything like that. The dog actually did come around, but not a standard, I would say, again. And then symptomatic treatment. So the main thing we're wanting to do is fluid therapy. This is something that is urinated out and can be reabsorbed through the bladder wall, so we want to have them having an increased urine production over that span of time. For tremors or seizures, diazepam, methocarbamol as well. Orally, I'll use in those kids. And then antiarrhythmic, again, I want to try and help with giving a mild sedative like a butorphanol or a low dose acepromazine like a 0.01 or 0.02 mg per kg dose of acepromazine before I reach for these antiarrhythmics. Like I say, if we're refractory to those first stage medications, then that's when I reach for these. Frequent walks is usually what we do. If it is a severe ingestion, sometimes we will place a UCath due to this reabsorption through the bladder wall, just to decrease the amount of their exposure. I think I've only ever had one dog have a truly, fatal chocolate ingestion if treated usually within the first 4 to 6 hours. It's those ones that we don't know, and then they come in like seizing, the baker's chocolate, dark chocolate, something like that. Those are the ones with delayed treatment that can have worse prognoses. There's just a little chart here. I would say if you have a VIN, there's the VIN chocolate calculator, which is amazing because it'll tell you can pull up what type of chocolate, the weight of your dog, how much ingested. Always choose the high end because you'd rather treat for that and have it not be true than vice versa. It has funny animations on it and everything. It's worth taking a look at. It's very useful. Grapes and raisins. Another one that we see all too frequently that owners leave usually more confused than when they came in with, as far as asking what's the dose of grapes and raisins that can cause problems. Anywhere from 1 to 1,000 can cause a problem because of this idiosyncratic reaction that they can have, and I have seen in practice from a dog that ate 2 raisins. It does happen. It is rare. It's really hard to convince owners to hospitalize for this 48 to 72 hours for a maybe. Is my experience. The way that I get buy-in for this, especially when I think that I need it, is because I explain to them what's going to happen if this dog goes into acute renal failure. It's not a pretty picture, and generally speaking, those owners, at least those ones that have like a high dosage, will usually hospitalize at that point in time. But the problem is that the signs that you're going to see are signs of acute renal failure. And so when you see signs, you're already very significantly affected. And you have some irreversible damage that is done because of that. I would say that more often than not, I'll get owners that'll sign a 48-hour one for diuresis, and then call the following morning and be like, never mind, I'm taking my dog home. Is a very common occurrence for me, or for people that will decline hospitalized care altogether. Now, I personally, before we knew about this whole grape raisin thing, is that I had a black lab that my dad gave grapes to on an almost daily basis, never had a problem. And so I was in veterinary school and I was like, oh, we're terrible people. Okay, got it. But it's rare, but the side effects of it are very significant. And so just letting the owner can make their own decision, but you need to give them the best case, the worst case, and then from there they can make their own call. I would say that I err on the side of caution and not like, never mind, he'll be fine, we'll just give him some soaky fluids and send him home. Do I do that a lot of the time? Yes, but I always make sure that they make that decision knowing what could happen. Some people just think that we're being fearmongers when we do that, but yeah, that's the fun part about being a vet. As far as specific treatment for it, we're wanting to watch our kidney values. Diuresis is the main treatment. A single dose of activated charcoal emesis to get up anything, especially if ingestion was in the last 2 hours. Gastroprotectants. I usually put these animals on famotidine or pantoprazole. I don't do Serenia unless warranted, except for our post-emesis. Permethrin toxicity. Becoming more prevalent, I feel. I see it more often now than I did before, and I think it's because of more owners getting these over-the-counter flea and tick. They can be giving the correct dose of some of these over-the-counter ones and still have problems, or the cat rubbed up on the dog right after he got his meds, or the cat accidentally got the dog's meds. I've seen any and all of those things at least 10 times. And so I would say that any cat that comes in mentally appropriate but twitching, having generalized tremors, is going to be a question of trying to get an answer via the history, because you're not going to see, usually, unless there's like a big oil spot on its back, you're not going to see that this cat had permethrin toxicity. So like I say, an accurate history is incredibly important in these animals. And then also keep it on your list of differentials for seizures. A cat that comes in acutely seizing, because in severe cases, these generalized tremors become so significant that they push right into seizures, and you just get a cat that comes in acutely seizing that's not being really responsive to a lot of the things that you're doing, and those cases can be difficult. So again, a history, very important. As far as treatment, first treatment right off the bat is bathing with Dawn or Palmolive. Now, if your cat comes in seizing, fair enough, not your first treatment. But in your mild to moderate cases, I would do this first. Beyond that, in those more severe cases where you're having significant generalized tremors, I would try and give a dose of methocarbamol or diazepam midazolam. I find that doing methocarbamol is very useful. Injectable methocarbamol is insanely expensive. So know that methocarbamol can be given per rectum via a same dose via a red rubber catheter if needed. I'll also use that in tremorgenic mycotoxin dogs that can't take oral doses. As far as dosage, I usually just do the 132 mg per kg per day divided, but I have had ER clinicians that just do 50 mg per kg as needed. Midazolam, diazepam works as a single treatment. If we're having significant tremors, I do midazolam CRIs as well. They can be really useful in these cats, not only for ones that are having seizures, but also the ones that are having severe generalized tremors. If you do have a cat that is having seizures that aren't being resolved by a dose of midazolam or midazolam CRI, you're going to want to start them on an anti-seizure medication, even if it's just for the short term. And then we're going to be reaching for those ones that you can bolus, so ideally a Keppra or phenobarbital. Propofol CRI, just like for all things tremors and seizures, it's kind of the end thing that you can do, but like I say, I would do midazolam or diazepam CRI well before I would try that. And intralipids, which are certainly making a resurgence onto the scene. I don't know how many of us have them in clinic, but they can be really useful for these different toxins that are susceptible to lipid sink. And this is the dosage that is for them, which is a very weird dosage that you'll use in nothing else, so I always have to look it up. As far as other supportive care, fluids, and then just monitoring clinical signs if we need, especially after a bath, a lot of times needing, a hot dog or a bear hugger or something like that to get our temp up. Sometimes due to our tremors, our temperature is very high, and then we're needing to kind of do some active cooling with them. So based on kind of where they're at in this, they could be in either direction. And then with severe tremors, we want to monitor our electrolytes. Generally speaking, otherwise, there's not a lot of blood work monitoring necessarily needed with these. You're usually fairly well out of the woods when you know that your cat has its clinical signs resolved. And with any tremors that are severe enough, technically you can have kidney damage. And so if you wanted to check renal values, that certainly wouldn't be a wrong thing to do. Marijuana. Speaking of a toxin on the rise, I think we probably average at least one marijuana case a day over the last couple of weeks, it seems like. It is a lipid-soluble medication, which means that intralipids are a possibility for it. Usually not needed unless it's a severe case. As far as the most common presentation is a dog that is hyperreactive, ataxic, and dribbling urine with mydriasis. I would say that that's probably the stereotypical presentation. If it's coming in like that, I'll usually have my technicians ask them if they had any marijuana, and if they say no, I still ask them when I go into the room, and then I let them know if they say no, and I'm like really looking at it, I'm like, this dog got into marijuana. Then I'll be like, well, if it's marijuana, the dog can probably go home on sub-Q fluids. If not, we need to do a CBC chem, urinalysis, ethylene glycol, hospitalized for 24 to 40. They're like, actually, there was this friend of mine that was over at the house, and he may have dropped something. It's like, interesting. Okay. To be fair, that's truly what you need to do, because your other differentials for a dog that's coming in showing those clinical signs are like ethylene glycol tox, some sort of medication ingestion, something that could be fairly severe. And so making sure that we get a good history, even though that history may be hard to come by depending on the owner. They don't believe that we don't care, and we don't care. Emesis can be useful in these cases. But again, I judge it based on their level. If we're like head bobbing, sedate, not useful. Activated charcoal, same thing. I'm monitoring what our mentation is. I'd say that my really severe cases that come in, we know it's marijuana. I'll start on IV fluids. I'll do supportive care for our clinical signs. If we're having tremors, doing methocarbamol or midazolam. If we need heat support, I find that these animals are more often than not hypothermic, but with severe tremors can be hyperthermic, and I do intralipids. I found it very successful in these animals. Usually a single dose can dramatically decrease their clinical signs. Now, most of these animals are not going to have fatal overdoses of marijuana. I'd say that the only ones that I've found are scary are usually edibles, or so dogs that get into an owner's edibles, or an owner that is making edibles and the dog gets into the garbage can. I've had multiple cases of a dog that basically ingests the filter that has the weed butter on it. Those are dogs that are in hospital for 2 to 4 days. It's very severe and concentrated, the amount of THC that they get. And dogs do not need it converted to smoke or anything like that. They can just ingest weed as is and become symptomatic for it. Lily toxins, which usually are extra tragic because it's usually a young cat that does it, and it's usually after either a holiday or a death in the family, because that's when lilies are in the house. At least in my experience, that's been more true than not. It's very serious. Anytime that an owner calls saying that their cat ate a plant, this is your first question: is it a lily? If they don't know what type it is, have them send you a picture. If they still don't know what it is, then just assume that it's a lily and tell them that they need to come in and get treated immediately. These here are your lilies that cause problem. Easter through Oriental from top to bottom here. There are a lot of other lilies, like peace lilies and calla lilies, that are not nephrotoxic, and normally those are going to be the ones that almost have they're kind of sled-looking cats, usually, specifically, where they're just like really hyper-salivating, everything like that, because it causes GI irritation, sometimes vomiting, for that same reason. As far as what we look for, if it is in fact one of these lilies here, it causes acute severe renal failure. It's, in my experience, usually fatal, and if we know that we ate it and we come in the first 6 hours, we do emesis, we start IV fluids, I usually tell them that we have a very good prognosis. If we find out that we ate a lily in our history and the cat comes in lethargic, vomiting, clinical, those are where we're in this category here, which I would say that I've had animals that are in hospital 10, 12 days and then are euthanized. It's just a negative prognosis, unfortunately. And the animals that do get out of hospital, they don't get out of hospital without obviously significant renal damage, so those are animals that can expect probably early onset chronic renal failure. Now in the acutely, if we're able to decrease ingestion with emesis, we never become azotemic or anything like that, then, like I say, good prognosis, everything like that. I wouldn't necessarily warn that they could have early chronic renal failure, but it certainly is a possibility. And so just something to avoid as far as just say no to lilies in your house, essentially, if you have cats. IV fluid care and inducing emesis is really all you can do outside of symptomatic care. But it's a nasty one for sure. Hemodialysis is an option. I know that Blue Pearl down in Franklin is doing dialysis. We do not. The rodenticide. This just kind of has information on your anticoagulant rodenticides, everything. This was actually from a presentation that was given last year that I took all this information from. And so, like I say, for any of these rodenticides, this is good information. I still especially have the owner have the label, bring the label with them, call poison control. That's going to give you prognosis. That's going to give you your documented treatment, just because there are so many of these things out there. Knowing what to watch for and how to treat is very important. So I would say I would lean on ASPCA specifically in these cases. Thank you guys for coming.